Okay, it's recording now. Okay, all right. So good morning, everybody. Today we're going to be talking about bleeps. So when you're in a hospital, obviously there will be times where something acute happens and they need help from a doctor, and they would like you to come and help them. If someone would be so kind, if they could just share the link to the meeting on the chat because somebody has asked for it. I'll see if I can find it for you real quick, and I will put that on here. Um, it should be in the email that I sent. I can't really find it at the moment. Just give me 1 second. Yeah. Oh wait, I got it here. Oh yeah, there we go. Okay, perfect. Sorry about that. Okay, so we're gonna be talking about bleeps today. This is a little bit of an interactive session. I thought it'd be better than, you guys just watch. So I would appreciate if somebody would volunteer to help out. I have 4 cases, nothing to stress about. It's gonna be a fun time, hopefully. And you'll see as we go, okay? The So today it's going to just be general cases that come up as a junior doctor. These are things that we usually typically get called about, and get asked to see a lot. So I think it's really good practice if we do this now here in a safe setting where there's no risk to anybody, not to you, not to the patients. Nobody gets harmed in this exercise, but I think it's really helpful because it helps you learn how to prioritize who to see first. What tasks are important, what tasks you can leave for later. And then it just gets you thinking on, oh, that's what I should do when this type of thing presents. And I think that's why it's a really useful exercise. I never had this, and I think most undergraduates don't get this because, again, the focus is different in medical school as opposed to what you do in real life. But hopefully this session can help fill that gap and hopefully build your confidence when you eventually do get called to see patients. So just a quick run through on how to handle a bleep. So, there'll be a lot of times where you just get bleeped, you call them back, and then they'll just say, "Hi, doctor, there's a patient with chest pain." Now, I have no idea who's calling, what patient they're talking about. Chest pain in regards to, like, have they been having chest pain all day? Is this new chest pain? These things like that. So obviously, I know that I think they've run through SBAR, and I ran through SBAR with you last time. So I know you guys won't do this, but you will still get a lot of handovers where you aren't sure, it's not being presented properly. So it gets very confusing and hard to keep track of who's actually calling you and what they're talking about. So what I found, and you pick this up as you go, but whenever you get bleeped, you I used to open the induction app every time and just check which ward are they bleeping me from, because I have a list of patients, and if I can find out what ward's bleeping me, then I know, oh, it's probably about this or this patient, and that already helps me thinking. When you do call them back, just make sure that it is your patient, because there's no point for them telling you like a 2-3 minute story, and then at the end you're like, but that's not my patient. I don't know anything about that patient. So always before they start, just be like, excuse me, right? Sorry, can we just start from the beginning if that's okay? What patient is this? Can I get their details? Can you tell me what's going on? And then you take it from there. It's really helpful because sometimes you can just solve the problem over the phone because you know enough about the patient. So they'll tell you, say, doctor, this medication is not prescribed. Oh, but it's because of this. We've already discussed this, and they don't know that. Or sometimes maybe like, the other day, the nutritionist called me and said, oh, why aren't we giving this medication? And I told them, well, because their electrolytes are, just deranged. And they're like, oh, yeah, that actually makes a lot of sense. And I said, yeah. So, you're just trying to help, just pass over information, and it really helps if you know the patient. If you can't solve whatever it is on the phone, and that does happen sometimes, just call, just go there, sorry, just go to the ward and go and see everything in person. Sometimes that's what you need to do, is just go and see the patient and all the files and all the details, and you can solve it out. If you cannot solve what's going on, that's completely fine, but just make sure that you escalate appropriately. So don't be afraid that, oh, they're in AFib. It's fine, it'll go away. I'm sure it's okay. It might go away. You're absolutely right. You give them fluids, it might go away. But it's still best to tell your senior. And most seniors are very reasonable, and they will be like, yeah, it's fine. Or they'll say, I come and see. They never get upset for you calling a patient. There's no one at any time. I've called consultants who are grumpy during the day at like 4 a.m. in the morning. But if you have done everything that you can on your end and you escalate to them, they're more than helpful, and they're usually grateful, because if you don't escalate, something bad can happen and they don't know about it, and then they'll get caught off guard. So it's helpful always to just escalate. There's nothing wrong with escalation. So I'm going to just show you what typically I do on calls, to keep track of all the bleeps and all the things I get. I would advise that, I mean, it's not like the standard way to do things, but I think it's very helpful. I'm going to run you through it. And then I would advise, in the meantime, if everybody could get a piece of paper and a pen for what we're going to do next, I think that would be very helpful. So when I'm on call, I usually have a piece of paper and a pen, and I'm running around the place. But whenever I get bleeped, I always, on the left side of my page, I'll write down, the details, like the hospital number of the patient, the name of the patient, where they are. So like Denver 34, Elm 13, surgical assessment unit 25, and then a very quick summary of whatever they tell me. Oh, this patient is post right hemicolectomy. Okay, 3 days, fine. And then have they had a CT scan? No, there's no collections. Oh, their cannula fell out. They just need IV antibiotics so their cannula fell out. Okay, fine. If you can see the boxes here, so whenever you get a task, it's helpful to keep track, like have a system keeping track that you've done it or not. So for example, for Mr. Mark Anthony here, he needs a CT scan. So what this means, I've created 2 boxes and I've kind of half filled this one. What that means is that I've requested the CT scan, but I haven't vetted it with the radiologist. So when you book a CT scan, you have to call a radiologist and tell them the story for them to be like, okay, we'll do it, or them to say, no, we're not going to do it. So I've done the first part, which is I've gone on the system, I've booked the CT scan, but I haven't vetted it yet. Once I vet it and the radiologist says, yes, we're going to do it, I'm going to cross out that whole box. And then this box means that I need to check the result. Again, everyone has a different way of doing it. Some people have ticks, some people have X's, whatever. I find the boxes make a lot of sense because anybody can take my sheet and they understand how far along I am on these tasks. Like this guy who's come in who needs his regular medication prescribed. I finished that. Okay, so no one needs to go and do that. But these are all the things that need to be done. I wish that my handwriting was this clear during my own calls, but it's not. But I hope, just for example's sake, this is how we do things. But yeah, this is kind of a good way of keeping track of cases. The reason why I'm showing you this is because I think it's a useful way to do it in real life. But B, I think some of you will be doing this very, very soon, if not all of you. Does anybody have any questions? Okay, that's completely fine. I would now ask for a volunteer to help me with what we're about to do next. I will explain everything, but we do need a volunteer. Basically, I'm going to pretend to give you a couple of bleeps, and you're going to just keep track of them. We're not asking you to manage anything yet. We might save that for later, but I think it's a useful exercise just to practice how to, how to take bleeps. Because I can teach you lectures and you can attend classes and you can see people doing it. But I think the best way to learn something practical, is to do it. So I have a few very simple cases. If any of you guys would be willing to be a volunteer, we can run through these cases. They're very easy, and it's the first person gets the easiest cases of the lot. So would any of you guys volunteer? All right.
I can do it.
Perfect. All right. Thank you so much for volunteering. So do you have a piece of paper and a pen?
I have like a Word document on the side.
That works.
Okay.
Okay. Are you ready?
Yep.
All right. Fantastic. So let's say you're a surgical F1, okay, and you're on call at night. Okay. This is a very real scenario that probably will happen in the future. Okay. So let's get started. So it's 3 a.m. in the morning. as these things usually are, unfortunately. And you get bleeped saying, "Oh, doctor, hi, Dr. Abdullah, there's a few things on the ward."
So what's going on?
Oh yeah, of course, doctor. So basically, there's a couple of patients that need a bit of help. So bed 10, they need some IV fluid. They're nil by mouth because they have surgery in the morning. Can you come prescribe IV fluids, please? Um,
Um, well, which patients?
yeah, yeah. So this is bed 10. This is Mr. Michael Phillips. He's a 59-year-old male. He's come in for a laparoscopic cholecystectomy tomorrow morning. He's fit and well. Otherwise, we just need IV fluids because he hasn't had anything for a few hours.
Okay,
All right.
all right.
And then, doctor, since I have you on the line, there's also bed 13. So they need antibiotics, but there's no space on the fluid chart. Would you mind just coming and re-prescribing it on another sheet? Is that okay, doctor?
Who is this patient?
So this is this is Salman. Salman, I can't pronounce his last name, doctor, but he's come in with with an infection of his small bowel. It says I can't understand, doctor, but it says that he needs antibiotics 3 times a day. He's on gentamicin, vancomycin. We've been giving it to him for a few days, but we run out of space on the drug chart. If you could
Okay.
just prescribe that. And then, and doctor, just one second. There's also bed 15. So this is the one of the pancreatitis patients. They're feeling a bit sick. They're on regular cyclizine, but can we give them something else? I think one of the other sisters, they said that we could give something PRN. Could you come and prescribe that, please?
Yep.
All right, perfect. Thank you, doctor. Thank you.
You.
Okay, and then they close the phone on you. All right.
Okay.
So so that's very realistic. That happens all the time. And the nice nurses will just bunch all the requests of the ward together and then just call you at once with everything. Okay? So I have you been like keeping track of that, I'm sure, on your Word document, right?
Yes.
So while you're sorting that out, I imagine you probably want to go to the ward or something. But while you're doing that, you get another call 10 minutes later because that's how these things go. So hi, Dr. Abdullah. We have a patient here. They're on IV fluids, but their cannulas come out. Could you come and pop another one in, please?
Their cannulas fell out.
Yeah,
Okay.
but that if you
Ed,
could
can
just.
you give me more information about the patient? Like,
Oh yeah, yeah, sure. It's Mr. John Smith. His hospital number is 35297. I'm not sure why he's come in, doctor, but his cannulas come out. Could you just come and put another cannula in, please?
okay.
All right, thank you, doctor. Okay, so that was another call. Okay, um, I'm hoping you're still with me here.
Yes.
Uh, okay,
Still
good.
with
So
you.
then you're probably on your way up. You're sorting out patients, seeing patients, and then you get another call 5 minutes later. And this is a very frantic nurse. Dr. Abdullah, we have a patient with chest pain. Could you please come very quickly, please, 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 doctor.
Okay. Has anything been done? And where is this patient? And can I get his name as well?
Oh, yeah, sorry, doctor. This is Mr. Peter Green. He's 52-year-old male. He's here in the and sorry, upstairs with us in the ortho ward. He came an hour ago with a tibia fracture. He has surgery in the morning, but he's saying that he has some chest pain, and he's having some shortness of breath. We haven't really done anything. I don't know what do you think we should do?
How's his saturation doing?
Oh, yeah, yeah. So we've just did his obs now, and it's stable. Everything is within normal limits, but he's just saying that he's having some chest pain. Would you like
And
us to?
Oh, yeah. Is there shortness of breath?
Yeah, there is shortness of breath, but he's still saturating fine. He's a
Okay.
bit tachycardic, maybe-ish, like it's borderline. It's like 15, 16.
Okay.
It's mostly just the chest pain. It was in the beginning, it was shortness of breath, but now it's just chest pain.
Which bed is he in?
So he's in bed 5 on the
Okay.
ortho.
Okay. Thank you.
All right, thank you. All right. Yeah, a bit scary, I'm sure, but that's how it goes sometimes that you just get one of these calls. And then I imagine you're heading that way, and then you get one last call on your way up in the stairs. Hi, Dr. Abdullah. There's a patient with stomach pain. Could you please come and see them?
Can you tell me more about this
Oh,
patient, where they are,
yes,
their
sorry.
name?
Sure. So this is Amy Smith. She's 22-year-old female. She's in the surgery ward. She's on bed 7.
Yeah.
Um, she had her pain. It comes and goes. We gave her paracetamol, but it's not improving. She had a surgery yesterday. Just let me check the notes. Oh, she had her appendix surgery yesterday.
Okay.
Um, but that's about it.
And she just has the does she have any fever or
No, no, doctor. She's just having some stomach pain. Otherwise, everything else is stable.
okay. Thank you.
All right. Thank you, Dr. Abdullah. All right. So that's what's it called? That seems pretty what did they say? Feels like a lot, I'm sure.
Yeah.
Um, but how do you feel?
Um I don't know. It's like overwhelmed. Like, okay.
That's
That's
understandable. So
that's a
one
lot.
thing to note is that I won't say it never happens because it does happen like that sometimes that you just get bombarded with stuff. But
Mhm.
usually there's a lot of time between things. But obviously for the nature of this lecture, where we've kind of condensed everything and like you have a good mix of things coming and going. If in front of you, you probably have a list of tasks. You could probably bunch them into 4 tasks, right? Like that's probably
Uh,
what
yeah,
you've
there's
done.
6. I can probably do them in 4. Yeah.
Yeah, like you have the first few patients who have come in with drug charts,
Yeah.
and you have the chest pain, abdominal pain, and then the cannula, right?
Yeah, the first 3 I can lump them together, and then
Yeah,
the last 3 probably.
yeah, they're like their own separate thing. I'm not going to ask you how to manage them. We will run through that, but I'm not going to ask you to do that. I just want you to make a list of who you would see first. And then
Okay.
for everybody else who's watching on the sidelines, I want to try something because I've heard that you can do this on Teams. I think I've set it up. So let me just see if I can launch it and if it works. So there should now be a poll where you can rank your decisions on who you would like to see first. Can everybody see this?
Yeah.
Okay. So you can answer on that as well if you
Okay.
want, but
Okay.
you're going to stick with me for a few minutes while we run through this. So we'll just give you guys like a minute to run through it, and then we will see and go through the results. Just more. Okay, so I can't actually see where the answers are that people have put in. I'm also not sure if this is working, but
I can
hope.
see them.
Oh, okay, yeah, I can too. Okay, sweet. Yeah, so everyone's put in this order, I think, which makes a bit of sense. So
Yeah.
Abdullah, do you want to tell me what you'd like to do, what order you'd like to see them, and what you would like
So,
to do?
it's like just an order of most pertinent in terms of like which one which require immediate kind of assessment, I would say. I would say for sure bed 5, Mr. Peter, with the history of the tibia fracture,
Mhm.
presenting with chest pain and shortness of breath.
Yeah.
Um, and then not the second one, I would say the post appendectomy, Amy Smith,
Okay.
with the stomach pain. I mean, that one I would say needs to be assessed out right after. And then, so the cannula that came out
Mhm.
versus now these last 2,
Mhm.
I'm not quite sure which one to put
That's fine.
3rd and 4th, but I would need more information about John Smith, whether like these IV fluids are like really, really like he really needs them, like he's dehydrated or something, I don't know. But I feel like they can go like both ways. Like I can go
Yep.
do the cannula first and then the drug charts.
Yeah.
The antibiotics, like they're not gonna die if they just don't, so
Yeah, no, that's very reasonable. I think that's very very well what's it called? Very well thought out. So
the
you're absolutely
pancreatitis patient though, I'm not sure. Like is she post like intervention or
yeah, well, of course there's always so many details, and again, if you can't get those answers, if you feel like, oh, this isn't being managed correctly, you can always go up to the ward and see the patient. Um, a lot of things you can solve over the phone, but I think you're right. If you have any doubt, definitely go and see the patient. But for the most part, yes, I agree with you. The most significant acute things first, and then everything else can come last. So this is the sequence that I thought of. Obviously, you can disagree with me here, but I can give the reasons why I've put it in this order. So first off, obviously chest pain, because if they're having a heart attack, obviously you want to go see them first. Over the phone, you asked the right thing, which was you asked for their OBS, because I think asking for OBS over the phone is helpful, which is why the new score is so helpful. Because I'll just ask the nurse, what's their new score? If they say 0, I know they're stable, and if they tell me like 5, then I'm like, okay, I should go see the patient,
Mhm.
rather than them running through every parameter. But obviously I can do that at any time. I can ask them, how's your heart rate, which is what you did, which is absolutely correct. One thing to note, when you get called to see a patient that you think you're actually going to go see, it's helpful for you to tell them to say, can you prepare their notes and their drug chart? Now, obviously, in a lot of hospitals, this is all digital and you don't need to do any of this. But in the hospital that I work in, a lot of the times the notes just go missing. It's terrible. I know it's absolutely terrible, but the notes go missing. So it's helpful for just the nurse to tell them, like, listen, I'm coming up in like 5 minutes or 10 minutes. Please have the notes ready. Specifically for chest pain, it's always helpful to ask for an ECG. So you can just ask them, can you do an ECG? The nurses are really good. They will probably already do an ECG without even calling you, because they know that that's what you're going to ask for next. But with chest pain, that's one thing to note. I agree with you. Abdominal pain definitely should be the next person who needs to be seen, especially someone who's post-op. It could just be simple abdominal pain, but it could also be something really bad, like, uh, I don't know, like dehiscence, which is the late complication. But it could be many things. So you obviously want to go and see a post-op patient first. I agree with you that the drug charts and the cannula can be done in any order. It doesn't really matter. Um, but I personally think that the drug chart is more important, because those things do need to be administered. Like that is their treatment. The patients are in hospital to receive that treatment, and if they don't receive that treatment, what's the point of having them there? The thing with that is, though, you can always tell them to just bring the charts to you, assuming this is a hospital where everything's not digital. Obviously, if any of you guys have rotated in KHUH, which I think all of you have, it's all digital, so you can do it from anywhere in the building. You don't need anything. But since we work in a paper-based hospital, you can just ask them to get a porter, and they can send you the things if you're too busy. For the cannula, you're absolutely right. Why do they need a cannula? If you think about it, a lot of patients and a lot of people overnight don't actually need water or fluids. They're asleep, you know. So even if they're nil by mouth, since midnight they were asleep, they don't, and their cannula's fallen out in their sleep. If their urine output's fine, they're not dehydrated, it's okay. They don't need any more fluids. So you don't actually even need to go and see that patient. I always ask, why do we need a cannula? Just the other day, there was a patient who is so difficult to bleed and cannulate. Like she has no veins left, bless her. She's very, very old. But someone's like, oh, can you just put a cannula in? And I said, why? And they're like, they had hyperkalemia, but then I checked the blood results and it had normalized. So I said, no, they don't anymore. So they don't need fluids and they're drinking. And so always just think, do I need to go and cannulate this person? Because obviously cannula is not fun. Especially if it's a difficult cannula, you need to call an anesthetist. It's like a whole process. So just think about whether you need to do it or not. But that was really, really good. Thank you so much, Abdullah, for your help. I hope that was helpful in any way. And well done. It's obviously very nerve-wracking to be the first person to go, but I hope you benefited from that. Moving forward, we have another set of bleeps. Can I get a volunteer, please? Anybody else who would like to volunteer? I promise I don't bite, and it's for your benefit. So if anyone would like to volunteer for the next set of bleeps, it's completely fine if you get all of them in the wrong order, but I promise you it's not confusing. It's all within the realm of your capabilities. And I think it's really beneficial if you give it a go. Would anyone like to volunteer? If no one volunteers,
Sure, I can try.
oh, thank you. All right, Hassan. I think there might be a bit of echo, but okay. So where I'm getting started, the name is last time. I think okay, I'm just gonna mute for the minute because there's a bit of an echo. But once I get to the question part, you can open your mic and you can talk. So you are now the medical F1 on call, okay? Medical nights tend to kick off a little bit earlier than surgical nights. Mostly, I don't know why the surgical patients seem to be okay, and then at like 3 a.m. they start crashing randomly. But medical patients they start from the beginning of your shift. So let's say I call you, hi, Dr. Hassan, it's 8 p.m. Hi, doctor, there's a patient who was admitted recently to the medical respiratory ward, but they don't have any of their regular medication. Could you please come and write them? Is that okay? All right, I think you might be muted.
Sure, I can. Can you tell me what they're admitted for?
Oh yeah, sure. This is Mr. Mark Smith. He is hospital number is 73590, and they did with effective exacerbation of COPD.
Okay.
We started antibiotics and doctors came and but didn't prescribe the regular medication. He's on some he says statin and some other medication. Come and do that, doctor.
Okay, your voice is cutting off a little bit. I'll pretend I heard all that.
Okay.
How are the patient's saturation of oxygen?
They're saturated. Listen, I think if you turn the volume of your computer, it might be better.
How do I do that?
Just on your computer. Like just the output speaker.
Output of speaker.
Yeah, or you can move microphone over here.
Here, can you hear me better?
I mean, I can hear you fine. I think it's looping. I think it's resolved now. Fantastic. Can you hear me clearly? Hassan? Hassan, you've disappeared. Dr. Hassan? We're having some technical issues, guys, which does happen with Microsoft Teams. Please bear with us. Dr. Hassan will return, hopefully, in a minute. His speaker's coming back and forth. But again, he's doing the right thing. Obviously, as you get more experienced, you don't always ask, oh, what's tell me all the details about the patient and all of that. But that comes with experience. I think in the beginning, especially during my first month, every patient that I got bleeped about, I always asked, can you tell me the name, the date of birth, the hospital number, the location, what medication they're on regularly, what are they admitted for, how are they doing, how are their obs. And now it's literally like, oh yeah, okay, I'll do it. Okay, just give me the number, note the number down. I don't even know the name of the patient. I don't like it. It's reached a point where I don't even need to know the name of the patient. I know exactly who they're talking about sometimes. without even telling. Like they'll tell me, oh, this patient's back from their procedure. I know exactly which patient they're talking about. But that comes with experience. In the beginning, it's definitely beneficial to just take it, take as many details as possible. Hassan, we can't hear you, unfortunately. It was working so well. Okay. For the rest of you guys who are here, I do have 2 more cases. So if during this time, if you could just gather your strength, because I will need 2 more volunteers. It's not to put you guys on the spot, but believe me, I promise you it's better that you do this here in this mock setting where you can literally go and do the cannula first and leave the chest pain patient, rather than in real life when those are actually real things that are happening. I think it's a useful exercise. We have lost Dr. Hassan, which happens a lot. Sometimes you call the doctors and they're asleep somewhere or they're just not picking up. So that is a realistic simulation of what can happen. Yeah, I will give him another 2 minutes and then I might ask someone to take over.
Can you hear me now?
I can. Welcome back, Hassan. How are you doing?
My God, I hate Teams. Okay.
I'm sorry. I wish I could do this in person. I think it would be a lot better, but obviously due to logistical reasons, I can't.
It's all right. Is it okay if I could just go on with what I was doing?
Yes, absolutely.
I think my voice is better now too. Um, can you tell me if the patient's taking any medications?
So at the moment, they've only been prescribed some antibiotics, doctor. And you said they're OBS, so they're fine. They're using 0. Their saturations are fine. But it's just the regular medication. They just admitted the patient and forgot to write their regular medications up. And they're supposed to get one of their medications tonight. So if you could just come and prescribe that, that would be really helpful.
All right, sure. I'm on my way.
All right. Thank you. Thank you, Dr. Hassan. So while that's going on, you get another, another call at 8:15, 15 minutes later on the way there. Hi, Dr. Hassan. This is the geriatrics ward. One of our ladies has passed away. Could you please come and verify the death, please?
Oh my, I'm sorry to hear about that. How long ago did she pass away?
So she was last seen alive 2 hours ago. We just went in to do her obs and unfortunately she had passed.
Okay, and are there any other nearby doctors who were caring for her?
No, unfortunately we're one of the outlying wards, so it comes under medical cover at night. All the regular doctors have gone home, so I think it's supposed to be you, doctor.
Okay, and is there family here?
No, we've called them. They're on their way. We haven't told them that they're passed, but we'll take care of that, doctor. We just need you to come and verify the death.
Sure, I'll be on my way. Okay, thank you.
All right, thank you. All right. So you got that call and you're on your way to the geriatrics ward or the previous ward. And then as these things go, you get another call. And hi, Dr. Hassan. We have a patient here who needs a VBG in 30 minutes, but unfortunately no one on the ward can do them. Is it okay if you come and do it, please, doctor?
Certainly. Can you tell me what it's for?
Yeah, so they have they have come in with respiratory alkalosis, and we just want to see if the fluids have improved. That's what the previous doctor told me. I don't actually know myself.
Okay.
And they said that we need to repeat it at 9:30. So if you could just come and do that, please.
Okay. And is the patient stable?
Oh yeah, the patient's fine. I mean, they're still breathing a little bit fast. They're still on oxygen, but they seem okay. Nothing. They're the same as before. They're still using 2 or 3.
All right then. I see. Yeah, I'll be on my way.
Okay. All right. Thank you, Dr. Hassan. Okay. So then, so that's been sorted, and then unfortunately, as these things go, you get bleeped one more time, and you got very busy. You know, there was new admissions. You got called by a reg. You hopefully also went and took a break. Very important to take breaks, guys. And then you get bleeped again before you actually got a chance to do any of these things. So at 10:10, you get Bleep saying, "Hi, Dr. Hassan. This is the geriatrics ward again. One of our patients is really confused and wants to leave. We have security here trying to hold them down, but can you please come help?"
Trying to hold them down.
Yeah,
Okay.
they're really confused and they're trying to run away. They're throwing slippers at everybody.
Okay. Are the other patients safe?
Yeah, they're fine. They're just kind of enjoying the show, I guess. But yeah, he's trying to, trying to run away. So I think if you could just get your help though as well, because they can just physically hold him. But I think maybe you should review the patient if possible.
Sure. Sure.
All right.
Okay.
All right. Perfect. Thank you, Mr. Dr. Hassan. Okay.
Thank you.
Thank you. Bye. Okay. So obviously a little bit more difficult than the last case, and then obviously we had our technical issues. But I think overall you took that very well. So what are you going to do now? What are you thinking? What's the sequence of events in your mind?
Yeah. So this is what I'm gonna do. Number one, I'm gonna
Okay,
get
wait,
to the confused.
Sorry. I'm gonna put a poll up again because I think it's cool that this exists. And then we're also gonna get your colleagues in as well. You can definitely just make that list in front of you and just get ready to present that.
I have a list.
Okay, fantastic. And then if you want, you can take it to the next level and then tell me what do you think you're going to do when you go and see the patient eventually, because you're going to go and see them in a minute. What are the things in your, what are you worried about type stuff? This is the next level. This is beyond what, I mean, if you somehow figure this out, you will be, well, you're already doing amazing, but it'll be even more amazing. Sorry, 1 second. I really should have set this up beforehand. So just to remind everybody of the four options. So we have a confused man in the geriatric ward who's throwing slippers. We have, and by the way, this is a real thing, so I didn't just make this up. This happens a lot, and I'll explain why in a minute. We have a patient who needs regular medication. We have a patient who's passed away, and there's a patient who needs a PBG. So here is the poll. Just everybody can go ahead and tell me what order they'd like to see everything. And hopefully it works. I think. We'll give it a minute and then we'll take it from there. And then Dr. Hassan will walk us through what they want to do. See if I can see the results. Okay. That's pretty good. All right. How many people are there? Alrighty. So Dr. Hassan, would you like to tell us what you would like to do?
Sure. The first thing I'll do is rush over to the confused patient because they might present a threat to other people. I'm going to go over them, introduce myself. I'll ask them what their concerns are, if they have any particular reason they're acting this way, aside from being confused. If they're difficult to approach, I might have to do it myself or have someone assess their capacity, see if they're capable of making an informed decision in the moment. I might have to look at their notes, see if they're either in delirium or they might be having some other cognitive decline. If necessary, I might have to get the security to hoister them down and deliver just to tranquilize them.
Okay.
The second patient I'm going to address is the VPG because it's needed in the next 30 minutes. So it's not an urgent, but it's sub-urgent.
Mhm.
And the patient could destabilize at any moment. The third one is going to be doing the like the blood work and the prescriptions. Sorry. Um, prescribing the meds for the COPD exacerbation patient, because
Okay.
their situation can also deteriorate, but it's not urgent and the patient isn't decompensating yet. And the last one would be to verify the death before the family arrives, and break to have enough time to secure myself and break bad news properly without upsetting the family.
Yeah, that sounds pretty good with me. Again, there's no right or wrong answer to these things, but obviously, if you can justify why you want to do something, it's always better. I also agree with the sequence that you've chosen. Again, going with most acute to least acute. Now, obviously, as dramatic as it is, yes. So I think the only thing I will note, but I understand why this happened. It's because of the technical issues. Because you did this with the first patient, and then you didn't when you came back. But if you took more details about the patients, because I think for the second patient, you don't know their name, you don't know what bed they're in, and you don't actually know where they are. So you'd have to call the number back again and get all those details, which is always an option. So don't freak out if you forget to ask, like, because there's been many times where I've also been like, I took everything down, I know that I have to do something, and then I realize I don't know what the patient is, I don't know where they are, so I have to call back and ask what ward is this, and where's the patient. So don't worry about that. But you didn't ask any of those details. But if you asked me those details, which again you did for the first patient, I know we had some technical issues. I would have told you that he has a UTI. He was admitted with a UTI. So urosepsis is a very common reason for patients to get delirious, especially if they're old. So that's probably what's happening to the first guy. I just want to verify. You can see all three boxes, right? It's not just like you can't just see one. It's all three, right?
Yeah.
Okay, all right. So yeah, over the phone you can ask them to get the drug charts ready and the notes. It's always helpful before you close the call. I agree. The second one should be the VBG. Again, it's because it's time sensitive, and we'll miss any deterioration, anything if it gets delayed. One helpful thing to do is just to ask them to get the equipment ready. So anytime I get called for a procedure, I always tell them, can you get everything ready? They want me to do a catheter, they want me to do a cannula, they want me to take some bloods. Actually, bloods they usually don't prepare because I can just do that myself. But like everything else that requires equipment that usually isn't typically stocked, I ask them to get everything ready. They need an NG tube, they need ABG. Sometimes we run out of ABG needles, so I ask them, do we have any ABG needles?
Okay.
But yeah, it's just helpful to have the equipment ready. I agree with you. And I think this part, because I think according to the poll, people flip the order of this. And I understand why, because I myself, until I verified a death, I also thought it was the most urgent thing in the world. But actually, you don't have to verify a death. Like, it's not actually that, because I mean, what's the worst possible thing that could happen? They've already passed away, right? There's no harm to patients because they've already passed. Like this is the final thing you're going to do for this patient ever, probably. So it can wait, and the regular medication things are more important because this is a patient who's still in our care, and it'd be best if we go and get them sorted first. It is helpful if you ask them as well to get the drug chart and the notes for the patient, and then for the verification, if you could have the notes ready, that'd be helpful. Yes, Abdullah.
Side question. It's actually about the death
Mhm.
certificate, death verification. When I was doing my elective in Newcastle, one of the SHOs I was following around, he was doing a death certificate, and then he went down to and got paid for it.
Okay.
What
Yes.
is that all about? I forgot to
So
ask him. I was gonna ask him, and I just completely forgot about it.
yes, so I can answer that. So death certification is so there's actually three things when someone dies. There's death verification, which is just a doctor, any doctor can come and verify that the patient has died. And we ran through this last time. You just make sure it's the right patient, no signs of breathing, no response to pain, no response to verbal stimulus, no pulse, no cardiovascular activity. no respiratory activity, and then you sign off that at this time the patient has died. That is verification. Certification, you need a cause of death, and you need a consultant for this. The consultant who's responsible for the care of the patient needs to write down a reason, and then the medical examiner's office will make a certificate which certifies it. That this is usually done the next day or the day after, because it's done during working hours. So if a patient dies at night, this is not happening overnight. But then the last thing is a cremation form. So if a patient wants to be cremated, the process is that a doctor who has seen the patient alive in the last 72 hours, I believe, they have seen the patient. I believe so. I might be incorrect here. But basically, it's something which is not a regular service. So if you choose to do it, you get paid £70 to fill out this form. So that junior doctor probably agreed that, yes, I will fill out this cremation form. And they got paid extra because it's not a task that we're usually supposed to do. So that's why they got paid. It was a cremation form. It wasn't a verification or certification.
Now that you've said it, I remember he said it was a cremation form, and he was actually like, he went to the finance thing, and they still didn't get his his money. So he was
Yeah,
like, okay.
we can talk about the whole NHS money thing at the end, but yeah, that's basically what happened.
Right.
I hope.
Sorry to segue from the
No,
thing.
no, it's completely fine. I hope that was beneficial, and it is always beneficial to share more knowledge. So this was the case. Dr. Hassan, thank you so much for your help. So this, I think, just like, again, getting used to taking bleeps, getting information, and then just in your mind thinking of, what do I need to do first? Because it's part of the. I mean, it can get really overwhelming sometimes. Like, oh my God, I have like 50 things to do. But if you organize it and you keep a list and say, oh, I'm going to do this and this and this and this, it keeps your workflow going, and that way you don't feel as overwhelmed. I will need one more volunteer. We're almost done. I realize that we're nearing the end of the session, but thankfully, it seems like previous me has figured that out, and we'll have one last case. Can I get one more volunteer, please?
I can try.
Yes, thank you. Is that Muaz? Am I saying your name right?
Yes, Maad.
Hi, Muaz. Thank you so much for volunteering. So it'll be the same as before. I'm just gonna give you 4 scenarios, and then we're just gonna ask you to sort it out, and then that'll be it. Okay?
Okay,
Ready to go?
let's go.
Okay. Hi, Dr. Maud. There's a patient scoring News 9. Can you please come quick, doctor, please?
Hi, yes, where is this patient?
Hi, this patient is in the frailty ward. They're in bed 7. Would you like all the details, doctor?
No, I think I'll come. Why was he admitted for?
So this is Betty Dove. She's 95-year-old female. She had a fall. So now she's
Okay,
admitted under our ward. At the moment, she's News 9 because her heart rate is high, so 112 is her pulse. Her blood pressure is low, so 96/72. She's on 3 liters of oxygen, and she's tachycardic, so her breath is 22 breaths per minute, but she's afebrile. She's been using 7 all day, and now she's 9. But I thought you should know, doctor.
okay.
All right.
Yes, I will see her.
All right. Thank you, Dr. Mahad. All right. So that's one patient, and then you're going to see this patient. Obviously it seems very urgent. There's this lady who's getting sicker, and then you get another call. Hello, Dr. Mahad. We have a patient with low blood pressure. Can you please help, please?
Yes, do you know the news score?
Yes. So the patient's news is they're using 5 at the moment.
Okay, and where is this?
So this is the urology ward. This is bed 3. This is Mr. Simon Baker. He's a 65-year-old male. I can give you the obs if you want, doctor.
Yes,
Yeah.
please.
So the blood pressure is really low. It's 80/60. And their heart rate is 109, and their temperature is okay. It's 37.5, and their respiratory rate is 20, and they're 97% on room air. I think we've already started them on antibiotics. Is there anything you'd like me to do, doctor?
Oh, why was he admitted?
Oh, they're admitted with urosepsis.
Okay. I will see him. I'm not sure. Not
Okay, all
sure.
right.
Yeah.
Thank you, doctor. Thank you. All right. So, obviously the two big cases have already come your way. This does happen sometimes, occasionally, every once in a while. But then you get another call. Hi, Dr. Mahd. Hi. This is the
Hi.
frail ward again. Unfortunately, one of our patients fell.
Oh
Um,
no.
we've started the protocol, but we checked their blood sugar and it's 2.1. Um, could you come and see, please?
Okay. And how are the rest of the other vitals?
Oh, we just did a set of obs. They're using zero. So this is Miss Barbara. She's 75. She was admitted with a leg infection. She was walking around the ward and she slipped. She had no head injury. She's type 2 diabetes, but everything else is fine.
Okay. Okay. Uh, I will see her.
All right. Thank you, Dr. Mahd. Thank you. All right. Yeah, I can sense the stress and worry, but you're doing great. There's just going to be one more call, which is now. Hi, Dr.
Okay.
Mahd. This is the respiratory ward. We have a patient who's desaturating. Can you please come and have a look?
Uh, what's their condition?
So this patient is Miss Lily James. She's a 65-year-old female. She was admitted with infected exacerbation of COPD. At the moment, she's
Okay.
saturating 88% on room air, and her respiratory rate's 30. She's breathing really, really fast.
Okay. Uh, and her news score?
So her new score at the moment is 5
Fine.
because of her low saturation and high respiratory rate.
Okay. Okay. I will see her then.
All right. Thank you. Thank you, Dr. Mark. Okay. So that was a lot, I know. But you did well. You took all the details. I'm just going to put another poll up, and then you can think about the order, and then we can discuss the cases. Just give me 1 second. I'm sorry I didn't set this up before, guys. I just Googled it a few minutes before the session, and I found out I could do this. So I will just put that up. I hope this is not too much. And even if it feels like it's too much, that's fine, because at least you know that this is something that happens. And I promise you it'll be better the next time. And that's the whole point of all this. Okay, so here is the poll. Give it a go, and then we will discuss it in a minute. All right, we'll give it another 10 seconds, and then we'll have a discussion. All right, Muad, what would you like to do? Hello?
Hello. Okay.
Hi, Muad. What would you
Yeah.
like to do?
So maybe I'll go to the News 9 first.
Okay, fine.
Okay. And then the
It's fine.
Yeah.
Whatever order you think. I mean, this is a little unfair, to be honest, because it's like, well, first off, a News 9 will also, a registrar will be informed as well, so it won't just be you. And
Okay.
then these are very acute cases. So this is literally the nightmare scenario, but at least now, you've run through the nightmare scenario. if you get even one of these patients, you'll know what to do, hopefully.
Okay, good. Okay, so my guess would be the news 9 first, and
Okay.
then maybe the one with the low blood pressure.
Okay.
Okay, and then the fall and the low blood sugar,
Okay.
and then the COPD, because I think 88 is normal for COPD. That's why
Okay. Fair enough. Yeah, I mean, I see where you're coming from, and I understand what you're saying. I will give you my answers, and they're a little bit different. But again, as long as everybody gets seen, it doesn't really matter what the sequence you do this in. But I think this is the sequence that I would go with, and here's the reason why. So you're right, 88 isn't too bad for someone who has COPD, but the fact that their respiratory rate is going up is not a good sign. It means that they're beginning to struggle at that level.
okay.
And when you're thinking about seeing patients, this is a bit morbid, but when you're thinking about which patients to see first, think about what will kill them first. So A, B, C, D, E. So airway breathing is first. So anyone whose airways and breathing is compromised, they're an emergency because they could die first, right? Circulation's after that, and that is definitely a problem. So that's why the blood pressure I put after that. And then D, A, B, C, D, disability. So the fall and low glucose. So low glucose goes under D, and I would see them through it. Number 9 is on its own. Yes, it's very bad. They need to be seen. But seeing as how you have so many acute cases, since they've been 7 all day and now they're 9, it just means one parameter has changed, but they've been doing unwell. Now, if they went from like 3 to 9, yeah, I would see them first, probably. They're worse than the patient who's in the rest ward, who's already COPD. We know that. But since they've been 7 and now they're 9, it's not that big of a change. For the patient, now obviously I didn't expect any of you guys to do this, but just for your own learning, whenever you get called by a patient on the phone, you should always, what's it called? When you should think about what can I do over the phone, or what can I start over the phone so that things are a little bit better and along their care when I go and see them. So for example, the patient who's now suddenly starting to desaturate and their respirate is going up, you can ask them to start oxygen, which they would have done anyway, but I left it there just in case you picked it up. Just ask them to start oxygen over the phone, and they will be more than happy to start oxygen. And then with any of the patients, just get their notes ready. You can consider giving nebulization as well. That helps. For the patient with low blood pressure, so on my placements so far, I've realized that a lot of times, sometimes just giving patients a bolus of fluid solves whatever problem they have. 500 ml of water apparently just solves like 90, not 90, but like 70% of the problems with a lot of patients. So if you get a call saying this patient has low blood pressure, just ask them, can you just give them some fluid? I will write the prescription when I come. Are you okay taking a verbal prescription from me? And in a situation like this, most nurses will say, yes, I will start the fluids. Please come and sign the chart when you come. And then just see if the blood pressure picks up in 15 minutes. Sometimes patients, they just get hypotensive because they haven't had fluids. You give them some fluids and they become a little bit better. The patient who fell, so their blood sugar was low. So you could ask them, can you just give them some juice? Can you just give them some glucogel, which is like a syrup which has a lot of glucose and it brings up their blood sugar. In the UK, they call glucose monitoring BM. I think it's because the machine they used was made by someone whose initials were BM, or there were 2 people and their initials are BM. So they call them BMs. So just repeat them in 30 minutes. Neuro-obs are very important because you want to make sure that there's not having a stroke or something. You can just tell the nurses to do neuro-obs. There's a sheet. They just make sure that their obs are fine. They check their reflexes and stuff. They'll take care of that, but it's always good to start that.
Question, what does OBS stand for?
OBS means observation. Sorry, vitals. Vitals, observations. They're the same thing. So when I say their OBS are fine, so it means their vitals are fine. So like their blood pressure, their pulse, their temperature, their respiratory rate, their saturation. So those are OBS. Neuro-obs are like their light reflexes, their tone, their power, their response to verbal, like their GCS. It's part of their neuroobs. It's just something that it's just something that they can objectively check on a patient. And then
Okay.
News 9 again. I do apologize. Is a little bit of a red herring. I put that in there just to kind of confuse you a little bit, but I think they do need to be seen, but I don't think it needs to be the most urgent thing in this situation. But yes, if anyone calls you and says that we have a patient, News 9, definitely need to call for help and go and see the patient. I think for sure. I hope that was helpful. And thank you so much, Muad. Thank you so much, Abdullah. Thank you so much, Hassan, for volunteering. I'm just gonna run through something which I think might be helpful. Is just when someone calls you for a cannula. We discussed this a little bit earlier, but just ask them, what do we need the cannula for? Nurses do like having cannulas because it's like, oh, they have access. We can do stuff without needing to put one in, and we don't need to call a doctor, and we can just do things. But if a patient doesn't need a cannula, you don't need to put a cannula. You don't need to give them one. So you need to ask, is this for IV fluids? Is it for IV antibiotics? Is it for blood products? Do you think their hemoglobin's low? They might need blood. And then also don't just because a nurse calls you and says, oh, can you put a cannula in? It doesn't mean that you have to go right now. You are not a cannula. You're not like a phlebotomist. You are a doctor. You have many things to do. Putting a cannula in is one of the skills that you possess, but it's not the only thing that you do in a day. So you just ask, have you tried? And then some of the nurses say, oh, doctor, I don't know how to do it. Just say, it's okay, just try. And if they can't do it, then you can ask them to escalate to the duty sister. So the duty sister is like the head sister of the ward. You can ask them, can you ask them if they can do it? I think 90% of the time they are more than happy to do it or try. If they can't do it, then obviously you will get called and you have to do it. It's okay if you miss. I honestly I miss cannulas all the time. I am more than happy to do any procedure, but for some reason I'm really bad at cannulas. But it's okay. Just try. Okay, never be afraid to try. And that goes with anything. Like, what's the worst that'll happen? You'll get it wrong. So what? At least you've tried, so you can escalate. So I've missed, and when I missed, that's okay. Now we can say that everybody has tried. We've all missed. Let's escalate this. Let's get an anesthetist in. They'll come in with their fancy ultrasound machine. They'll probably get it in. Sometimes they miss as well. Then you need to go get an interventional radiologist, and then they'll probably get it. But again, there's always a ladder of escalation. So just do your role in that ladder of escalation, and hopefully everything will be resolved. I hope this was helpful. Does anybody have any questions? And if you could be so kind as to do the feedback, I would be more than grateful. So please, if you could fill that out. It takes 2 minutes. It's really... Sorry, Abdullah, did you have a question?
No, I just said thank you.
Oh yeah, no worries. Happy to help. Yeah, I hope this was helpful. I know it's a lot.
By the way, do you need stuff for your portfolio? Like, do you need feedback for your portfolio?
Yes, that's why I need the feedback.
Oh, because I have an NHS like email, so I can do the because
it's not one of those feedbacks
okay, never mind.
So I just need there to be some feedback to say that there was some feedback. I don't need a formal no one's going to review it, but I just need to say that there was feedback. So you can just fill out the simple form that I made on.
Oh yeah, okay.
On Google, it just makes things easier because I know that those forms take a lot of time to fill, and you have to be highly motivated to get somebody to fill them out. But if you could fill, I'd be more than happy.
All right, thank you.
Yeah, no worries.
I have one question too, if you mind me asking.
Of course. How can I help?
I'm pretty sure you've been asked this by other people too. I'm just 2 weeks out from writing my SJT.
Okay.
At this point, I've done the 3 practice tests that are posted on the website. I'm saving that online one on that Prometric website, a few days beforehand. Do you have any other suggestions about what I could be doing?
So for the SJT, so my SJT was different to your SJT that you'll take now. So I did the FY2 SJT, which is just the ranking questions. So it's just the questions where you rate from 1 to 5. And you say it's very desirable, very undesirable, and then everything in the middle, like somewhat desirable, somewhat undesirable, and then not either or. I only had those type of questions. So I can tell you about those, and then I can tell you just tips in general. So for those ones, the ranking ones, you have to treat every STEM individually. So for example, you'll get a case, right? You'll say one of your colleagues comes and admits that they've been taking sleeping tablets from the cupboard, for example. And then they'll give you questions. They'll give you like 5 questions based on that scenario. So one of them would be like, oh, you report them to the GMC, or you report them to a consultant, or you ask one of your colleagues what to do, and then you have to rate that decision from 1 to 5. Now, a mistake that people make is they'll be like, oh, the previous question, I wrote that as a 5, as in most desirable. So this must be a 4 because it is very desirable, but it's not as desirable as the previous one. The thing is, they could both be 5. Does that make sense? They could both be very desirable, or they could both be very undesirable. Do you know what I mean?
So it's on a question by question basis.
Exactly. It's on a question by question basis. Do not treat the next question based on what you answered the previous question or the previous STEM. Do you know what I mean by STEM? As
Yeah.
in like, yeah. So don't treat STEMs together. Like, don't say, oh, the last question I wrote a 1. So this has to be a 2 because it's not as bad as the previous option. No, they're both bad. They're both not supposed to happen. They're both 1. The
Okay.
other thing I did was that I played a statistics game. So let me see if I can write here. I think I can. So let's say can you see this on the screen?
Yeah.
Yeah, so you have options, right? You have 1, 2, 3, 4, 5, right?
Mm-hmm.
Okay, I don't know what's on there. So let's say this is least desirable and this is most desirable, right? Let's say least desirable, 5 is most desirable. I don't remember which one it is, but let's say for this example, that's the case. You get given a STEM which has some good elements and some bad elements. So for example, let's take the same example with the patient or the case where your colleague has come and said, I'm taking sleeping tablets from the cupboard. So I remember this because it was so funny when it happened. One of the STEMs that I got was you ask your nurse in charge if they do it as well. So the good element of this is you ask your nurse in charge. That's great. That's a good thing. You should talk to your nurse in charge. But then the bad element is you ask them if they're also doing the wrong thing, right? So it's not 1, obviously, because it's not good. I mean, it's not bad. And it's not 5 because it's not purely good. So you have 3 options now, right? The answer is either 2, 3, or 4, right? So most people are inclined to take a gamble. Okay, they'll either say, I think it's more bad than good, I'm going to go with 2. Or I think it's more good than bad, I'm going to go with 4. I did something, which is I looked at the statistics of it, and I went in the middle every time. So let's say the answer is 4, or the answer is 2, sorry. So this is the correct answer, okay? If you chose this, you get 4 marks. But if you missed and you chose 4 instead, you get 2 marks. But if you take the middle one, you get 3. So every time I was faced with a decision like this, I went with 3. So I never got the maximum mark, but I never got the worst of the 2 marks. I always got the middle mark. And I scored quite well on my SJT. And I think part of the reason is because of this. I never gambled. I always took the middle road. So that is something to consider. This is not for every question. This is just for those questions where you don't know what the answer is. There will be moments where you're like, I have no idea what the answer is. And then on top of that, the other thing for the SJTs, you need to keep track of your time. There's a lot of people I know who just didn't finish the paper. Automatically, unfortunately, they wouldn't be able to, it's very competitive. The good news is for F1, it's not as competitive as FY2. FY2, you have a 1 in 10 chance of getting it. But it's a lot better in F1. So the statistics and it's on your side, so don't worry. Have you done the GMC in action stuff?
What do you mean?
So there's a website called GMC in action. I found that very helpful because it's like scenarios made by the GMC, and they basically talk about what their reasoning is behind the answers that they give, like their decisions. Does that make sense?
Okay.
I will see if I can get that link for you. Just
You
give me a
mean
minute.
like the good practice one?
Yes.
Like that purple one that's 40 pages long?
No. So that's a document. You should read it. It's a very boring read, but I recommend you read it. But the GMC have turned that document into an interactive website. And I
Okay.
think that website is very helpful. I will send the link for that in a minute.
Just found
I-
it.
Oh, did you find it?
Yeah.
Yeah. So it's gmc/uk.org/GMP in action /
Okay.
and their scenarios. And I really recommend everybody who's sitting the SJT to go through them because it subconsciously trains your mind to think like the GMC. You figure out what they want. That is unfortunately all the advice. Sorry, that's all the advice I can give because I only ever did the ranking ones. I don't know about the other questions.
No, this is good. Thank you.
Yeah, no worries. Happy to help.
And just one other thing too. I think most of the people in our class are going to be writing online, and this overall suggestions are just write in a room, be really quiet,
Yeah.
write away from a mirror, keep your screen bright on. Do you recommend anything else to make sure, we don't get flagged?
I mean, I've sit a few online exams. Obviously, our final paper were all online thanks to COVID. I've I so I was the class representative for the year that we did that. So the way that they run these exams is they have this big, like it's a pretty big company. If assuming it's the same company, they have like a huge like monitor and they have everybody who's sitting the exam. They're tracking your eyes. So they actually they can see if you keep looking in like a specific corner. My advice to you is I know that people reflexively when they think, they always just like, they look up or they, I
Yeah.
would really advise that when you're thinking, you either just close your eyes or you look at the screen. Try not to like do the thing where you're like, I wonder what it is, because what it looks like is I'm looking at something that's stuck on the wall behind me.
Okay.
I think they might ask you to show the room before the exam. At least that was for us, that they ask you to take your laptop and just show the room. So that should clear all of that stuff. But yeah, I think the biggest thing is that it just needs to be a room where you don't get interrupted. One of my friends, unfortunately, he gave an interview and his little niece walked into the room and it was like a huge issue where they had to he had to grab her and put her outside, but it breaks your flow. So just make sure that no matter what happens, unless the house is on fire, nobody can get into that room, just for your own mental focus sake. Try to make it like exam conditions. I would not recommend doing it in your bedroom or a room that you spend a lot. Like if you have a study room, do it in your study room. Don't do it in your bedroom because you're not gonna, like, naturally, if I had to give an exam in this room, I think I'd do really badly because my bed's right there and I'm very comfortable in this room. So for me to have to do an exercise which requires a lot of focus is really bad. I would go downstairs to my living room and I would probably do my exam there. So just make sure, like, environment and setup. I think for any procedure in life, whether it's like a catheter or cannula or anything, preparation is key. Positioning and preparation. So just try to do that.
All right. Thank you.
Yeah, no
And
worries.
one other thing too, I'm really sorry. Do you know if there are any places, we have a higher chance of practicing our skills with those procedures like, arterial blood gas or catheterization?
So when you come to the UK, you can go and talk to, every hospital has an education center or like a simulation center.
Yeah.
I mean, if my hospital has one, I promise you every hospital does. You can go there and you can ask them, I'd like to just practice. So when I came in initially, obviously I had been out of clinical practice for a year because I was doing my master's. And then on top of that, in Bahrain, they don't actually take bloods or do ABGs or all that stuff. So I was really bad at it. And, by the second week, I was like, this is ridiculous. Like, I need to practice because I keep missing all the time.
So I went there and I said, hey, I need some practice. They just looked at me like, you're an FY2. And I'm like, I know, but I just need some practice. So they left me with their models. And for the whole day, it was a quiet day. I just practiced with their models. So they have loads of arms and like devices and all that stuff. Nothing beats the real world. So obviously just practice. You will miss, that's fine. But just go and practice you have to practice on people at some point, you know, and just go and see patients and do their bloods and, you know, take samples. You will miss, and that's fine. And in my last lecture, we can talk about all of that, which is the ward procedures and stuff. But yeah, just ask somewhere to practice. There are places to practice though. You definitely get to practice, but nothing beats the real thing. Definitely just try to get some real world experience.
All right. And one final thing on the feedback survey you brought back, it says one question fully in Arabic, like the first question.
I think it's because your Google account probably, or by default, your language is set to Arabic. It's just asking for your email.
Okay, I understand.
Yeah.
Thank you.
That's on Google's end, not mine. Alrighty, guys. I hope that was helpful. I know it was a lot, but I hope it helped out. I'm gonna stop the recording now. Thanks so much for your time, and hopefully I will see you guys in the next one. All right. Just take care.